judgments and decisions regarding varicocele repair, we can show you data either way. There is data to show you that there is no improvement, there is data to show you that there is significant improvement, and you have to be judicious here. So you have to understand, one, how is this a patient who's going to actually, because he's a patient to you, is he actually going to benefit? So very, very clearly you should look at varicoceles which are clinical, because that is something which is common in both the data. It has to be a high grade varicocele. More likely with secondary infertility rather than primary infertility, you're going to get better chance of success, because there's a far higher incidence that you're going to encounter varicoceles there. And more likely with multiple semen parameter abnormalities. So if you're going to look at a couple where the man has come in with single sperm parameter abnormality, you're far less likely to show improvement in this patient than someone who's got both concentration, motility, morphology, and possibly DNA fragmentation abnormalities. This is someone who's possibly going to show you much better improvement. Now this is another controversial thing. Varicocelectomy in non-obstructive vasospasmics. Do you do it or do you not do it? And again, there is data which is really, you find it difficult to believe, but there is data which shows that 40% of these men, if you did the varicocelectomy, will have sperm in their ejaculates. I've never had sperm in ejaculates even without doing any surgery in anybody in a non-obstructive vasospasmic, until unless it was a wrongly assessed sample. So you find this difficult. We've had far fewer men showing sperm in their ejaculates after varicocelectomy. Very frankly, we've had very few. But it does increase the retrieval rates. And that's something we found. Especially since we started using micro-TZ, we are finding better retrieval rates in men that have had high-grade varicoceles and non-obstructive vasospasmia. They have relatively normal testicular volume. It's always difficult with the non-obstructive vasospasmics to say they'll have a normal testicular volume, but they have a relatively normal testicular volume. They have high-grade varicoceles and they have non-obstructive vasospasmia. You can then operate them and expect to retrieve sperms by micro-TZ. Again, the other procedure is not good enough. You cannot do a testicular sperm aspiration or even a TZ to get sperms in these patients. There is mention of histopathology making a difference. Again, very well received, because we know that with Fertivison or early maturation arrest, especially with early maturation arrest, we will not even attempt, because there's practically no chance. With Fertivison, extremely low chance that we'll be able to retrieve any sperms. But if we're getting late maturation arrest, if we're getting hypospermatogenesis, there's a far better chance that we'll get sperms on microdissection TZ. And DNA fragmentation, I'll talk a little about this, because this is actually not validated currently, it's not into the guidelines. So you cannot operate on normal semen parameters with DNA fragmentation abnormalities only as part of the guidelines, but we are beginning to do it. So if we are finding persistent infertility, if we are finding men with high DNA abnormalities, and we find no other correctable cause, it is a high-grade varicocele, we are going ahead and doing varicocelectomy in these patients. There's a very interesting journal which is totally on this, which is in the Translational Andrology, Urology in the September issue. The entire issue is based on DNA abnormalities and clinical uses, and there's a lot of discussion about what you can do in varicocelectomies there. Quickly we'll move to what procedures we have. So we have the inguinal or the high retroperitoneal approaches, the laparoscopic, the microsurgical repairs, and embolization. I've put in these procedures so that you understand that a lot of this is offered. This is the only acceptable form of how to repair a varicocele, which is a microsurgical approach. If you are an experienced surgeon, you can do a subinguinal approach for microsurgical varicocelectomy. If you are learning microsurgery, it's far better to use the inguinal approach, because you'll get larger veins, much easier, much smaller number of veins. You'll not get the 3 to 5 veins which are necessary. There's a lot of study which has shown the benefit of doing a microsurgery repair over a laparoscopy. In fact, what you see is that the arterial injury chance will be much lower, the recurrence rates extremely low, and extremely low complication rate. So you will have a much better chance of good outcome with a microsurgical repair. Again, you are able to ligate all the vessels except some vessels near the vas. The basal vein is left alone and you preserve the testicular artery, and sometimes you get more than one testicular artery to preserve. My preferred incision is the subinguinal incision. You can use a wink incision. If you're beginning, you can use an inguinal incision. Sometimes if you have someone who's having a concurrent hernia, you can use an inguinal approach. Thin men, recurrent varicoceles, also you can use an inguinal approach. The thing we're doing recently is also using Doppler in these men, because that allows you to ligate all the veins that need to be ligated and preserve all the arteries that need to be preserved. So this is an interesting tool, and it really allows more veins to be ligated and more arteries to be preserved. The complications we know is hydrocele, recurrence, very rarely testicular atrophy. Even if you've tied the artery, it's very rare to get testicular atrophy. We'll show you a short video of what kind of magnification you can get with a high power magnification. We use from 10 to 25x magnification in our patients who undergo a varicocelectomy, and you can see this vein. You'll actually see it almost looking like an IVC here, but it's under high power magnification that you're seeing this testicular vein.
Very nice video, Dr. Vineet, but you have outlined.
So I'll just quickly wind it up then. 1 second. Let me escape this. What we've shown here also is the use of intraoperative Doppler, but I'll skip that now. This is a short video, but we'll skip that. So end of the day, what you get, the final image, is only the artery, nerves, lymphatics which are preserved, and the vas which is preserved. Everything else has been laid bare. That is how a varicocelectomy done microsurgically should look like. And to summarize, diagnosis primarily on physical examination, only clinical varicoceles to be operated, only by microsurgical approaches, preferable subinguinal, and there is data to show that there is improvement in semen parameters and pregnancy outcomes. Thank you for your kind attention.
So, a question to you. Like here you have shown that only artery remains in nerves and this.
Four structures.
Right, all the veins are cut.
Yes.
So how the blood which flows in flows out?
So you have a lot of chance. In fact, within itself also there are posterior veins that we are not going to touch, which are outside the spermatic cord. We didn't go into the details of the video here, but this involves opening the spermatic cord and then going into the veins into the pampiliform plexus and leaving only the basal veins which I mentioned. So you are going to leave the basal veins which will dilate once you've ligated all the other channels, and you have a lot of other channels which are forming collateral. So you have posterior veins which will drain out from the inferior epigastric veins. So essentially a lot of system which is going to have collateral channel flow outside. You want to minimize the regrowth of veins within the cord, because that's going to lead to recurrence, which is why it's very important to make sure that you've ligated all except the basal veins.
Right, thank you. Are there any questions from the auditorium to our three speakers? We had very good three speakers who highlighted about azoosperm and everything. Yeah.
Yes.
So, a patient with recurrent IVF failure, all female factors are normal. Even the male semen parameters are normal.